Hello, everybody, and welcome back to BioSC 140 Human Physiology. This video is going to cover Laboratory 19, Glucose Tolerance Test. In this video, we're going to learn about the glucose tolerance test, what we would do in lab to do a glucose tolerance test, and we're going to learn all about how blood glucose is regulated and some pathologies that are related to blood glucose levels. Diabetes, to be specific. So let's get right into this. So the glucose tolerance test, GTT, in lab, the way we would do this is we would pick 6 students to be our subjects for the day. So 6 groups, 6 students. Actually, this one we kind of do as like a whole class. We don't so much break up into tiny sections. So 6 students, and those 6 students would be asked to not eat breakfast, not eat for 12 to 15 hours before the lab. Now, this doesn't always happen. Some students forget and eat breakfast, and that's fine. I mean, we're not diagnosing people. We're not doing this for healthcare reasons. We're doing this for education reasons. But for a glucose tolerance test, if you're doing it for healthcare reasons, you shouldn't eat for 12 to 15 hours beforehand, or you might get erroneous answers, erroneous data on yourself. So in class, sometimes people eat, but you're not supposed to beforehand. And in a clinical setting, you would take a large amount of glucose tablets. So you would take a large amount of glucose at one time. In class, we use jelly beans. So we have our 6 subjects eat 75 jelly beans in about 5 minutes or less. Now, I don't know if you've ever tried to eat 75 jelly beans in 5 minutes, but that's a lot of jelly beans. And so our students, when we do it in class, don't always get through all 75, and that's fine. You know, we're doing this for education purposes. We're not trying to make people sick in class. But usually there's a few people who don't get through all 75 and a few people who do get through all 75 jelly beans. Each jelly bean has 1 gram of carbohydrate within it, simple sugar, glucose. And in 1 gram of glucose, there's 4 kilocalories of energy. And then what we do is we measure their glucose about every 30 minutes for the next about 3 hours. Now in lab, we don't usually make it for 3 hours. It's usually about 2 or so, 2.5, 2, just because of the time restraints. But if it was a clinical setting, we do it for a full 3 hours. And we also monitor their their urine glucose, the presence of glucose in their urine. So in lab, we have our volunteers take a urine cup down to the bathroom after about 30 minutes after they eat their jelly beans. And they put their sample in the urine cup, and then they take a little a dipstick, a little thin piece of paper with it's like a test strip, and they dip it into their urine, and based on the color that it changes, it will tell us if there's if there's glucose in their urine. Of course there's urine in their urine, but glucose in their urine. And then they dispose of that in the restroom, and they come back and report the results to us. So with the glucose tolerance test, we have time 0. We take blood glucose levels here, and then every 30 minutes, we test their blood glucose. An average response, a normal subject, we're going to see their blood glucose rise some and quickly go back down. Their body's going to be able to respond to that glucose and bring it back to a normal level fairly quickly. We're going to see that response, that peak, around 30 to 60 minutes or so, but pretty quickly. In a diabetic subject, that response is not really going to happen. You can see how in this diabetic patient, the blood glucose just goes up and up and up and stays up. So normal fasting glucose levels are about less than 100 milligrams per deciliter. Normal person, the peak of this glucose level arc is going to be 30 to 60 minutes. Like we saw up here, the peak was right around 30 to 40 minutes for that example. Right here, you can see our peak is about 30. It's a little bit lower at 60 and back to normal after about 90. And it's going to end up at a normal level, and it's going to get there pretty quickly. So we're at the normal level after 90 minutes here. A pre-diabetic person, fasting levels are going to be about 100 to 126 milligrams per deciliter. We're going to reach the peak a little bit later. It's going to be a little bit slower to get back down to its resting or its fasting levels. So you can see here with this pre-diabetic person, we've got a higher starting point. It takes a little bit longer to peak. We see the peak here at 60 minutes. And then it's a slower response back down to its fasting levels. In a diabetic person, our resting levels are high, above 126. That peak takes more than 90 minutes to get to the peak, and it's very, very slow, if ever, to get back. Very slow to get back to a normal level. On a quiz, I might show you a graph like this. I might give you a table with the data points, so the blood glucose levels every 30 minutes, and ask you which one of these lines or which one of these subjects is a normal blood glucose, or which one is abnormal, which one's pre-diabetic, which one's diabetic. So be ready for a question like that. Here are the criteria. A normal response, the peak is after 30 to 60 minutes, and it's very quickly back to that normal level below 100. Pre-diabetic, higher starting point, peaks around 30 to 90 minutes, and it's very slow to get back to its fasting level. Diabetic person just goes up and up and up, and then has a very level rate after that. All right, let's just dive right into it and do one video for this lab. So here's the discussion for Laboratory 19 glucose tolerance test. So how do we regulate our blood glucose levels? Well, we've got two antagonistic hormones that do it. And we've talked about these hormones a number of times throughout this semester. They exhibit antagonistic control. One increases blood glucose levels, one decreases blood glucose levels. They exhibit tonic control. So in a normal situation, there's always going to be some insulin and there's always going to be some glucagon. The insulin-glucagon ratio regulates metabolism. So there's always some insulin, there's always some glucagon, but the ratio between the two, is there a high level of insulin, low level of glucagon, or vice versa? Our set point, so the typical fasting, so that's 12 to 15 hours of fasting. Typical fasting blood glucose is 70 to 100 milligrams per deciliter. I think in the notes it says 60. It's kind of a ballpark range, but any question that I ask on the exam, it's going to be either of those numbers is going to work for the questions. And if it's a writing question, I'll accept both of those answers. I've posted a video that you can check out. And where do these hormones come from? Well, they both come from the same neighborhood within our bodies. Insulin comes from beta cells within our pancreas, and glucagon comes from alpha cells within our pancreas. Insulin secretion is affected by plasma glucose concentration, remember these brackets refers to concentration, parasympathetic and sympathetic stimulation can increase insulin secretion. Glucagon is affected by plasma glucose concentration, again, and by the sympathetic nervous system. Insulin is the hormone of abundance. So why is it called the hormone of abundance? It's called the hormone of abundance because when you have an abundance in your life, you are able to eat and eat and eat and eat and put more sugar and more sugar and more sugar into your bloodstream. And so you need to produce more and more insulin to help bring that down and stabilize your blood glucose levels. So insulin, what is the goal of insulin? Insulin acts to decrease your blood glucose concentrations. So blood glucose levels go up because you ate 75 jelly beans. Insulin will decrease blood glucose concentrations and bring it back down. It does this by increasing glucose transport into cells. This is the most famous kind of function of insulin that you might have heard of before. Increasing glucose utilization. So as we learned in the metabolism section of this class, we can create energy from different biomolecules. It'll increase glucose utilization for energy. Increase glucose storage. So another thing that we talked about in our metabolism section. So it'll make more glycogen out of that glucose, put it in storage, and also decrease glucose production. So decrease gluconeogenesis. So decrease glucose utilization. Increase glucose utilization. So glycolysis, increase glycolysis. Increase glucose storage. So glycogenesis. And perfect. Targets. It targets the liver. The liver is where we're going to be producing lots of glycogen. Same with the muscles, lots of glycogen, adipose tissue. Put that glucose in storage. Glucagon dominates during fasting. So glucagon works antagonistically. Its job is to increase blood glucose levels. It increases glucose production, so gluconeogenesis, creating glucose from glucogenic amino acids, from glycerol, from lactate, increased gluconeogenesis, and it decreases glucose utilization. Also, glucose production can come from glycogenolysis, so the breakdown of glycogen into simple sugars. Target is going to be the liver. The liver is the main spot for this, for creating new glucose and for breaking down glycogen. So this is kind of just an overview again of our procedures. Fast for 12 to 15 hours. Eat a whole bunch of jelly beans. In a clinical setting, they don't give you jelly beans, they give you glucose tablets. Measure blood glucose in urine after 30 minutes. And then in lab, we only do the urine glucose one time, but we do the blood glucose every 30 minutes for up to 3 hours. These are the charts again. Again, be familiar with these and be ready for a question on it in the exam, on the exam. Normal, the fastest starting level is under 100. Pre-diabetic is 100 to 126. Diabetics above 126. We get the peak after 30 to 60 minutes for the normal one. We get the peak 30 to 90 minutes for pre-diabetic. The peak is 90 minutes or more. It just keeps going up for the diabetic one. Some vocab. So fasting blood glucose diagnosis. So hypoglycemic. Hypo, too little, below. glycemic, referring to glucose, below 70 milligrams. I believe in the notes it says below 60. Both, once again, both are acceptable for the exam. This could be because of too much insulin or too little glucagon. It's not very common. Hypoglycemia is not super common. Normal is 70 to 100. Pre-diabetic is going to be 100 to 126 fasting blood glucose. And then diabetes mellitus, hyperglycemic, so too much glucose, above 126 at fasting. At fasting. Please take note, some students get messed up. This is at fasting. And know your vocab words. Here it is again. Be able to differentiate between the 3 lines for the quiz. So diabetes mellitus. Within diabetes mellitus, there's going to be 3 subcategories that we're going to talk about. Causes of diabetes mellitus is inability to produce insulin. That's going to be a certain type, and increased insensitivity of insulin receptors. The person makes insulin, but their body doesn't respond correctly. That's going to be the other 2 types. We're going to get into each of those types pretty shortly. What are some common signs and symptoms, though, of diabetes mellitus? Well, all of them. Hyperglycemia is a common sign and symptom. So we just went over that. Too much glucose in your bloodstream. Glycosuria, so urea, urine. Glucose, so glucose in the urine. This is why during the glucose tolerance test, we test for glucose in urine. You're actually not supposed to have glucose in your urine. Glucose is a valuable resource, and your body doesn't want to just urinate it out. So it only does so when blood glucose levels are super high. We're actually going to get into the mechanics of that shortly. But generally, you don't have glucose in your urine. If there is glucose in your urine, think diabetes. Lipid and protein metabolism, so ketoacidosis. Polyuria, so poly meaning many, and then urea meaning P, so many P. Polydipsia, many thirst. Dehydration, which can lead to increased blood viscosity and poor circulation. Polyphagia, so poly again, many, phagia, eat. It's like macrophage, the same root word there. So polyphagia, many eat, so they're really hungry. My brother's diabetic. My brother's type 1 diabetic, actually. And I've heard this story from, or these symptoms are really common. These are kind of the famous ones, like, where is it? Polyuria is kind of like a famous one for diabetes. There's other symptoms, though, that are not on this list that are super common. That are, I think, the most common first sign and symptom is actually fatigue. They can't get the glucose into their cells, and so people get tired when they develop diabetes. So fatigue is actually a really, really common one. Thing about fatigue, though, is, it could be because you didn't sleep well. There's lots of things that cause fatigue. So, if you're fatigued, don't instantly think you have diabetes. For my brother, he was a sophomore in high school in his fall semester, and he noticed that he was having trouble reading letters in his schoolwork, reading like printed words in books in his schoolwork. And so he goes, oh, Mom, I need glasses. And, a lot of people in my family have glasses. So they go to the eye doctor, and the eye doctor gives him glasses, and he can read again, and everything's fixed. Everything's fine. And then a few weeks after he got his new glasses, they weren't strong enough. Even with his glasses, he still couldn't read. He couldn't visualize letters clearly. And so he goes, I don't think this is an issue with my eyes. and he hops on Google, types in his symptoms, goes back to my mom and goes, "Mom, I think I have diabetes." She goes, "What? Why?" And he tells her all the symptoms, one being, this rapid change in visual acuity. And she goes, "Oh my gosh." And so she takes him into the doctor, and he gets tested, and sure enough, diabetes. And once he got his diabetes under control, got his glucose levels back to normal, he didn't need glasses. And he still doesn't need glasses. And it's 20 years later. All right, let's move on. So type 1 diabetes, this is what my brother has. Some people are born with it. Some people develop it throughout their childhood. My brother, again, was sophomore year of high school. It happens because pancreatic beta cells are recognized as foreign and targeted by the immune system. So it's autoimmune. So your own immune system will attack these beta cells and kill them, so they can't produce insulin. The treatment, along with healthy lifestyle, you take insulin. My brother injects insulin many times a day to maintain his blood levels, his blood glucose levels. So he simply doesn't produce insulin. My brother has zero ability to produce insulin on his own, and he is completely reliant on taking synthetic insulin, completely reliant on it. Type 2 diabetes. Type 2 diabetes is adult onset, is another name for it. It usually happens to, you guessed it, adults. And most diabetes in the US is type 2 or adult onset. And these people are still able to produce insulin, but their body doesn't respond to it as well. Their body doesn't respond to it as well. Causes can be visceral or central fat, so that's not, fat on legs. It's having a big belly. Belly fat tends to produce different hormones and large amounts of certain hormones, which can lead to this. Age and genetics. General lifestyle factors are associated with it. So kind of the stereotypical unhealthy diet, lack of exercise, all that can lead to type 2 diabetes. Treatment, exercise, diet. So lose weight, exercise, eat a healthy diet, and in some cases, bariatric surgery. So surgeons will go in and literally decrease the capacity of a person's stomach, so they just simply can't eat as much. And it's actually really effective. Drugs. So drugs that inhibit liver glucose output, they block gluconeogenesis. There's a number of different drugs that are taken in different situations for type 2 diabetes. Type 2 diabetes is actually also really common in the elderly. My grandma had it, and she wasn't particularly overweight. She was normal grandma sized, and age can play a factor. Perfect. So knowing about diabetes is really, really, really important. Most of the people in this class are on a career trajectory where they will have patients in front of them. You will be face to face with a patient that you are helping in a healthcare setting. Diabetes is so incredibly common in our society. You will have patients in front of you that are affected by diabetes. Guaranteed. If you have patients in front of you, you will have patients with diabetes. Diabetes causes a lot of issues in our society, a lot of monetary costs associated with it, and a lot of quality of life issues associated with it. Now, my brother, he's been diabetic since He was a sophomore in high school. He's now like 34. He lives in Colorado. He has an awesome life. He mountain bikes and, runs and swims and, does all that outdoorsy stuff. He's got a dog, good job, all that stuff. So, he's living a really good life, but diabetes is still affecting his life a lot, his quality of life, even though he's able to do all those things. He's got to inject himself with insulin many times a day. When he goes out to eat at a restaurant with friends, he's looking over the menu and he's got to do math and calculate how much insulin to take after that meal. I can say from personal experience, if his blood glucose levels get off, if he's not completely accurate with the amount of insulin he takes, it changes his mood. He gets grumpy if his blood glucose levels go low. He gets really grumpy. And on top of all that, the quality of life stuff, his life expectancy is still decreased because of his type 1 diabetes. And that's not a good thing. On top of that, many people in our society who have diabetes have a lot of other symptoms and issues because of their diabetes. Blindness. So a lot of these more extreme symptoms either come after having diabetes for many, 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 many years, or when people don't take care of themselves the best when they have diabetes, when they allow their blood sugar levels to fluctuate wildly, to stay high for a long period of time. They don't really they don't really keep their blood glucose at the right set point. Those people they can get it early onset, really quickly on, they can develop some really bad symptoms. Blindness. Diabetes leads to a lot of blindness in the United States. Diabetes leads to a lot of peripheral neuropathy. So people who simply can't feel their feet, can't feel their toes, can't feel their fingers or arms or hands. And in some cases, it can, not even be a numbness, it can be a burning feeling. You can have burning pain in your feet, in your toes, in your arms, in your hands because of diabetes. And it doesn't go away. You just have this burning feeling. When you lack feeling in your feet and in your legs, it can lead to balance issues. I've seen diabetics walking with canes because their balance is so bad because they can't feel their feet. What else? It leads to a cardiovascular disease. It causes a lot of issues when it's uncontrolled and not maintained well. So look at these prevalence numbers. 11.3% of all people older than 20 years old. 1 in 10 people older than 20 years old are affected by diabetes. When you get over 65, it becomes about 1 in 4. You're gonna have patients in front of you that are affected by diabetes. Non-Hispanic whites around 10%, non-Hispanic blacks around 18.7%. So there are some, risk factors. There are some trends to, where it's more prevalent. In the Bay Area, people are generally healthy. In the Bay Area, people generally live a fairly healthy lifestyle. They're outdoors, they're eating good food, all that. Colorado, I know my brother, people tend to go outside and exercise a lot in Colorado. So they have relatively low levels of diabetes. So right here, county level estimates of leisure time and physical inactivity. So the more inactivity there is in certain parts of the country, the more diabetes we see. County level estimates of diagnosed diabetes. So there's certainly some regional trends. The South has a lot of diabetes. Right here is a large Native American reservation. So there's large Native American population right here. I used to live in South Dakota, so I know right here and right here are again large Native American populations. Same with Oklahoma. So there's ethnic trends, there's regional trends, there's lifestyle trends that all play a part in diabetes. Overall risk of death among people with diabetes is twice that, so not good for life. Estimated direct and indirect costs $174 billion. We spend a lot of money on diabetes. Direct costs are going to be the cost of the healthcare, and then indirect is going to be due to disability, loss of work, premature mortality. So eat well and exercise. The last type of diabetes that we're going to talk about is gestational diabetes. So gestational diabetes results from a decrease in receptor density. So if you have the same number of receptors on a cell, but you increase the size of that cell, the density of those receptors, the presence of those receptors on the cell is going to decrease. About 2 to 5% of all pregnancies you experience gestational diabetes. Causes are going to be placental hormones. The placenta produces a lot of hormones which can cause these changes in cells and cause insulin sensitivity, increase cell size. So you increase same number of receptors, larger surface area, you decrease receptor density. So in our society, nowadays, every woman who's pregnant is going to get tested for gestational diabetes. Effects, it can be increased fetus size. So if there's higher levels of glucose floating around where that fetus is developing, it can be a big baby. So more calories, more sugar, larger babies. It's also associated with some more negative effects, though, increased morbidity and mortality rates, and increases the risk of developing type 2 diabetes later in life for the mama. Supplemental data. So here's some practice data. You can see the normal test down here. You can see the pre-diabetic test here and the diabetic test here. Expect either seeing one of these graphs or a table like this on the test. Be ready for it. The last thing, I think this is the last thing, one of the last things that we're going to talk about is why is there glucose in the urine of somebody who has diabetes? Well, so diabetes means lots of urine, like sweet, lots of urine. Actually, I want to preface this with something. The ancient Greeks knew about diabetes. They noticed that people who had this collection of signs and symptoms that are diabetes, insects loved their urine. Ants would swarm everywhere they peed because there was lots of glucose in their urine. The ancient Chinese and Koreans, they wrote about diabetes, and the same thing. They wrote about people with these signs and symptoms who had really sweet urine. They had glucose in their urine. So diabetes is not a new thing. It's something that's been around for a long, long time. And even ancient societies around the world knew about this sweet urine disease. So why is there glucose in the urine of somebody who has diabetes? So kidney glucose receptors exhibit specificity, competition, and saturation. Saturation. That is why there is going to be glucose in the urine of somebody with diabetes. So the way our kidneys work, here's an analogy. It's kind of like cleaning your refrigerator. So this is renal physiology 101. We talk about renal physiology at the end of the semester, but 101 renal physiology. The way your kidneys kind of clean your blood is they start by pulling everything out of your blood. So if you clean your fridge, the way you clean your fridge is you pull everything out first, right? That's what your kidneys do. Then you clean the fridge, and you put the stuff that's important that you still want back in your refrigerator, and that mayonnaise from 1992 that you found in the back of your fridge, you throw out. The bad stuff you throw out. Glucose is valuable. Glucose is important. Your body wants to put your glucose back into your body after it pulls it out of your bloodstream. There's only so many transporters to move that glucose back into your bloodstream. There is a certain number of glucose transporters. They transport the glucose at a certain rate, and at some point, there's saturation. If there's more glucose than can be transported back into your body, that glucose will stay in your urine. It will not get, it gets pulled out by your kidneys, and some gets transported back in. Normally, all of it gets transported back in, but there's so much glucose that your body can't transport all of it back into your body, so it stays in your kidneys and gets urinated out. It exceeds the transport maximum point for glucose. Perfect. So right here, transport maximum. You increase blood glucose concentration, you increase the rate at which glucose gets transported back into your body, increase the rate at which glucose gets transported back in your body. At some point, you cannot transport glucose faster back into your body out of your renal tubules, and so anything above that is going to get urinated out. Right here, increased rate at which it gets moved back. Right here, you keep increasing concentration, and once you reach that saturation point, you're going to start urinating out. That's the green line, urinating out glucose. If you have any questions, let me know. I will see you all in the next video.